Thanks a lot, Eric. Prof, it's actually scary, you know. The more he presents, the more scared I become, because it just shows how daunting the task is. But I think the good thing is now that is that with this type of workshops, the picture is starting to emerge. What is that which we are dealing with? Because even up to today, a number of South Africans still don't understand. Many believe NHI simply means you are going to bring the medical aid to everybody, even the poor, and allow all of them to attend the most expensive private hospitals. That's the belief, at least. I even caught some leaders doing so. I caught a leader who was addressing a big mass meeting, and I got goosebumps because he said, yes, NHI is coming, even you're going to go to a private hospital, which is not entirely wrong, but that's not exactly what we are creating. But I also heard during the first transport strike, not the most recent one, which ended yesterday, one of the leaders there, in trying to bring their challenges to the fore, why they are complaining and why they are on strike. Because all strikes in South Africa now are characterized by one clear thing. There will always be a complaint about the medical aid subsidy at all times. If you check all strikes, whether public or private, there is a demand on increase on medical aid subsidy. Now that gentleman was saying the employer is not subsidizing us enough, and our members are forced to use public hospitals. It's a union leader, imagine. Not an ordinary person, a union leader who was saying, look, our members are forced to use public hospitals because we are not giving enough money. Now, what's wrong with those statements? Why do they give me goosebumps? First of all, if you check in South Africa, the medical aid subsidy has been increasing at more than consumer price index for the past 12 years. It has been just going on and on and on. But the benefits are reducing. Many of you who have got medical aid to realize that your benefits are reducing at an alarming rate for that matter. They are reducing every day. Now that brings the issue of the cost. And Prof, we just experienced these ideas, and I'm happy that as I was listening to you, you were apportioning concepts or terms to the ideas. Like when you talk about the Bismarckian model, yes, I didn't know that, but I realized that that's what some of the people think we must do. Because obviously, as you correctly say, many people believe in South Africa the present model of medical aid in private care, we must just build on it. Leave it as it is, built on it because they believe it's good. In other words, they believe it's good benefits already. What they do not understand is that even that is collapsing. It's not going to last very long. And I'm speaking with very serious conviction. I wouldn't have said so maybe early last year. But my last meeting before going out for Christmas, my very last meeting in the department was with medical aid schemes. All of them. All of them came to me and said, look, Minister, we now need your leadership on this issue. We're going to collapse very soon because the costs are just getting out of hand, completely out of hand. They're getting out of control. And many people believe their benefits are reducing because their medical aid is the one that is taking the money. It is the cost. And now I realize, Prof, our cost here mirror the cost of healthcare in the United States of America. We are as expensive as the American healthcare system is, which you are telling us never to emulate. But we are already in it, believe you me. It's getting there very fast. So I'm happy that you gave a sort of structure to it. and that which we need to avoid. And I think these are the decisions that we are going to be taking in South Africa. We can't build on the present system because it's not an ideal one. Yes. And because it will be too expensive to do so. So that brings me to one thing, I mean to the second thing then, which I said yesterday in the budget speech. Eric has just very wisely added the other two, which I think needs to be added, because in my thinking, I was saying South Africa has got two problems to solve. If we have to have a surviving NHI, there are two big problems that we need to solve. The first one, as I said yesterday, is this cost of healthcare that is running away even from the rich. That is bringing medical aids even to confront me. It's very clear. That has forced the Minister of Economic Development to ask for a market inquiry. We need to solve that and solve it very fast. That is the first problem. The second one is the quality in the public healthcare system. Whether we can ever improve it for the people, the majority of people, to still choose the public healthcare system as their first choice. Something that many South Africans are not dreaming about, especially the type of South Africans I'm addressing today. They get very angry in their hearts. They may not show me because most of those here are working with me, they won't. But those who are working outside this department, including my own colleagues in cabinet, when you tell them this, they get angry, they believe you are mad. You can't be educated in South Africa and use a public health system. That's the general belief now. And it's entrenched. That's why Lord Nigel Crisp did ask us very early on when he came to help us establish the national health insurance. Having run the national health system in Britain, having been the CEO, he asked me this question privately. He said, Minister, tell me, what do you and South Africans get into? What actually is that what you're planning? And I said, why, Lord Nigel? He said, I've realized that here in your country, everybody who has got a name and a title, they think when they are sick, they can only go to a private hospital and nowhere else. And he said in Britain, we still have the rich, the famous and the mighty going to utilize public hospitals. And he said we can come and see very famous people, mighty people and very powerful people are still using the public sector. But in your country, you seem to be believing that's impossible. And that's why you find the leader of a union of truck drivers openly and angry, because I saw him on TV and I was aware that many South Africans don't understand the impact of that. Telling the nation that, no, you must give me enough money. The workers working in this truck driving industry must never find themselves in any public hospital. Give them enough money to go elsewhere. You know that amount of money doesn't exist. Yes. So the issue of quality in the public health system, I think, is the biggest premium that perhaps we have to pay as South Africans. Maybe more than the United States. My belief, Prof, is that looking at, I haven't really gone much into Obamacare, but I thought what Obama is faced with are only two problems, even though they might be big. I thought there are only two. That he needs to bring the cost under control, if ever he will, because that's the biggest problem the Americans are facing. And secondly, to look for resources to cover the 16% of Americans. I think it's 53 million people that you spoke about. I believe once they do that, their job is over. It's finished. They will have paid their price by just bringing down the cost, finding a way to cover 16% of the population. Our ambassador to Qatar showed me a document where Qatar is starting NHI in July this year, and they are finishing next year. They will have completed. Also because they are not faced with the type of problems that we are faced with. Certainly not the problems of quality. And I think they've got more resources than us. So all they have to do is to find the mechanism to cover the rest of the population. That then brings me to a question I asked the executive director of the World Organization for the Africa region. And he said, Dr. Sambo, he said the World Organization is working towards a common official definition of universal health coverage. We don't have it yet. We kept on adding some terms and all that. It's not yet complete. And he said perhaps it will take 2 years. And yesterday I was trying to outline it, that we need to reach consensus on a definition that it means every citizen has got a right to access to good quality, affordable healthcare system. And that access must not be determined by the socio-economic condition of the individual. I think that is an ideal definition. And when you look at that definition, there are key words there. The first one is every citizen. And I realized that in the Bismarckian model, every citizen didn't apply. They were picking the cream, yes. So the first catchword is every citizen. The second one is a right. Now, in our South African Constitution, it's already there, it's embedded in Section 27. In fact, the organization called Section 27 in South Africa, many people don't know that it was formed for us. Yes, it was formed for us in health, and education just inadvertently got into the eye of the storm. And then they ran with education. Yes, Section 27 of the Constitution is speaking about health as a right. That is a right, blah, blah, the state must take reasonable steps. So Section 27 was formed to force us to make that right a reality. It had nothing to do with education. They just give them, you know, it's a gift on a silver platter, and now they've forgotten what they were formed for. But I think once all the books are delivered, they are coming for us, believe you. They will be coming to us. Yes, so the right is already there, but is it being exercised? Access. I think the issue of access, we have done it in South Africa. We have opening up apartheid, that you can go anywhere. But is it practically possible, even when the access is open? Then comes good quality. And then comes affordable for the country, I think, not for the individual. And lastly comes the socio-economic condition of the individual. And I think when we start building the NHI, we look at these keywords: every citizen, right, access, good quality, affordability for the country, and socio-economic conditions of the individual. And what I was saying yesterday, when I say countries will pay different prices, because countries have different objective factors. My understanding is, in this among these keywords, how many of them? 1, 2, 3, 4, 5. I think there are 6 keywords. Each country is going to find which word applies to them. And in my understanding, Barack Obama is dealing with only 2. The affordability part of it, and the issue of covering every citizen. I think so. Then they will have completed their job. And I think in Qatar, the reason that they are starting this year and ending next year, they just have to deal with every citizen. And then they will have completed their job. I'm not sure what other countries will be faced with. But I'm giving the example of those 2. Now, let's come back to Africa. In Africa as a continent, for all of us, and I think for all the countries, my biggest suspicion is that all the 6 words are not there. The issue of every citizen, the issue of a right is just on paper. The issue of access is also on paper. You can't access something that doesn't exist after all. Yes. Same as what the president of Nigeria was saying when he addressed the parliament last week when he said there is a belief that South Africa and Nigeria are fighting who will represent Africa in the Security Council. He said there is no fight because that seat doesn't exist for Africa. You can't fight for something that doesn't exist. Yes, so I'm saying we too, we can't talk of access of something that doesn't exist, even if it's on paper. And now good quality. Because if the services are good in public hospital, you wouldn't be having this unionist speaking like that. While I'm blaming him, but he was expressing what he's experiencing. He was expressing what he's experiencing, that no, we can't be going to the public sector there. Only poor people go there because there's very poor quality. That's what he was expressing. So that is another key way. Then affordability, of course. One of the reasons why many people are fighting that NHI is not affordable in South Africa. And there are many prominent scholars who fight like that. Very early in 2009, a very eminent professor of economics at Stellenbosch shared the platform with me when we were addressing the College of Medicine of South Africa. And he was saying, according to his estimate, that was 2009, he said NHI is going to cost 850 billion rands. By that time, it was the total budget of the whole country. Yes. Not of health, of the whole country. And he was saying it's going to cost that much, it's unaffordable. And of course, I was very emotional and angry that this professor has gone mad now, you know. Where does he take this thing from? But a few months later, I realized that he's actually right. He was telling the truth. Actually, he was not mad. He was right because he was calculating it on the present model we are having in South Africa, which is characterized by what? By all the good people going to private health care only. And the public hospitals offering nothing. But by a health system that is curative and not even trying to prevent any disease from happening. But by the more than anything else, the present pricing structure in private health care, where they just call any amount of money, any amount I'm emphasizing. So that's why I was saying it's not going to be affordable. Now we know better. It can be based on the present model. And of course, the socio-economic conditions of an individual is determining. The irony about South Africa, when it comes to that, is that we had 14 healthcare systems in this country. 14 systems of healthcare under apartheid. I don't know whether the young Sisulu's understand what I'm saying. Looking at their age, we had 14. Depending on your tribe, depending on where you find yourself in the country, depending on your color, etc. Those 14 were abolished by the interim constitution in 2004. I mean in 1994, sorry, the interim constitution. And the final constitution adopted in 1996 abolished the 14 healthcare systems. So that will remain with one. But today, 19 years later, when we wake up, we find that we actually have two. Yes. They are not in any constitution, not in any law. They just established themselves in some form of a natural progression of events. You have got one that is private, very heavily resourced, with human resource, everything. And then the next one is public, which is supposed to be for everybody else, which everybody, even workers, are running away from. Taking again from that weight of the truck, the leader of the truck union. So all these six needs to be looked into if we are to be successful. But I want to argue that in South Africa, the biggest success here lies in one of these six, the good quality in the public sector. If we can achieve that while fighting these other battles, if we can just fight that issue of good quality in the public sector. Because I was telling my colleagues in cabinet, I'm not saying so because there are professors here Professor Boo, but I said that. And I said it 3 times in cabinet, and some of them get angry. I said, actually, in this country, the best doctors you can ever get are in the public institutions. But nobody believes that. Even educated people. Yes, the best doctors are in the public institutions. Because they are professors. Yes. That's why now the private sector is stealing professors from the public through these RWAPs I was saying yesterday. It's because they are the best. Otherwise, they won't be stealing them. They won't bother about them. They'll actually say they come from the public, they are poor quality. They are the best, that's why they want to poach them. But the reason that they can't bring out their best is because of the mediocrity that we are allowing our institutions to wallow in, which I said earlier on, in the earlier session. The issue of good quality, where there's no functioning equipment, they run out of drugs, the X-ray machines are damaged, the infrastructure is not maintained, there's no information system, etc., etc. That's what characterizes the public sector. If we can solve that part. Now, I'm not the only one viewing things that way. I got a document which was a speech delivered by Louis Sambo, the director of Wealth Organization in the Africa region, is based in Brazzaville. In July last year, he called ministers of finance and ministers of health in Tunisia to discuss the universal health coverage, or NHI, in Africa. And he said, he actually proposed, he said, I wish to propose 4 main thrusts for attaining universal health coverage on the African continent. And he said, if we follow those, then we'll be on the way to implement universal health coverage. And he said the first is to strengthen the capacity of the public healthcare infrastructure. That's what he said. It's the first one. Strengthen the capacity of public health infrastructure to provide effective, safe, and quality health service. Then he went on to say this infrastructure is talking about, it includes staffing, buildings, technologies, utilities such as power and water supply, waste management. This seems to be obvious, by the way, but in Africa it's not that obvious. These things I'm talking about here. Power supply, waste management, transport and communication, and financing and maintaining recurring costs. He said that is the first thrust. If we don't deal with this in Africa, then these other things will never happen. They will follow after this. And I think South Africa is faced with us more than anything else. The second is then coming about raising sufficient resources. Only then going to try and raise money. And the third is talking about removing financial risk barriers. I'm sure it's, to allow the poor people to come in, remove all these risk barriers. And he said the fourth thrust is about promoting efficiency of the National Health Service to optimize resources and maximum results. But in my belief, that fourth thrust that doesn't even come if you can do the first one. I believe they are one and the same thing, really. That's what he has proposed. Then I started noticing, when I read this, that is actually 100% right. Because without this first one, which I want to repeat, of infrastructure, meaning staffing, buildings, technologies, utilities such as power and water supply, waste management, transport, communication, maintenance of recurring costs, and maintaining buildings, etc. I realize it's right, and that will be my conclusion. And why am I saying so? Because I was very excited to learn that healthcare in Angola is free for everybody, whether you are a pauper or a billionaire. As long as you do everything in a public hospital, whether it's neurosurgery or what, it's free. And I was very excited, that we need to follow the Angolans urgently. because it means they've already got NHI. But then I discovered that we can't, because it's free but non-existent. And I was told so by, yes, it's free but non-existent, in that the quality has just been removed. It's not there. So they say it's free, you can go there and do neurosurgery and all that, but there's nothing. I'm sorry to use those strong words. I'm trying to emphasize the issue of quality, that the quality has been removed. Now, before you laugh and say I'm using strong words on Angola, we did the same thing here in South Africa. People might not be aware of it. We did exactly that, and it never worked in trying to build up. When Madiba came in as the president, do you remember he declared free health care for pregnant women and children under 5? Do people still remember that? Do you think the population regard that as something phenomenal? No. They are no longer talking about that. It's not seen. They are talking about what they don't get when they arrive there. Yes, because in other words, Madiba declared for us that treat these poor people free. We agreed and say, Madiba, thanks, we'll do it. But then remove the quality. Remove the services, in other words. You are removing the services if you remove the quality. So we are more or less what Angola is faced with. And when I look at graphs of the National Health Account data set, the strategy that's happening there is that if you follow them up, Africa is busy privatizing health for the citizens to, yes, it's busy, in fact, it's moving fast in that direction. Europe and South America are busy following a socialistic model of health. That's the reality. You see it in graphs, you see it in what's happening. In our binational commission, I met the Minister of Health in the DRC, and he told me something very scary, very, very scary. He said they've reached a situation where, because their hospitals can no longer perform most of these things, their public hospital, bit by bit, in other words, the quality is going down. And so what do they do to improve it? He said, no, if people come to our hospital and there's a procedure we can't perform, we give them $10,000 and say, go down to South Africa. He said, that's their solution. And of course, meaning coming to private health care in South Africa, it can't be to us, by the way. $10,000. And of course, if you give a poor person $10,000 cash when they are sick and say they must go to look for health care somewhere, they will never go, obviously. They will sit and chow their money and come back to you when they are sick. And I told the minister, this is not going to work. He then said, no, we have got another solution. Netcare is coming to take over all the hospitals in the DRC. I said, oh, God bless Africa. God bless Africa. And he was very excited about it. Then I discovered in the World Organization Africa region called in Cote d'Ivoire 2 years ago, I discovered that that is what many of them think is the correct direction to go. Because they said we saw it in South Africa. It's working very well. Yes. It's working very well. We want to follow that model. Like we are saying we saw it in America, it's working very well. When the yes, we are saying so we saw it in America, it's working very well. And the Americans know it's not working. The rest of the continent said we saw it in South Africa. And we believe it's the board model. When South Africans know it's not working. So finally, I think what will work is to follow this model this proposal by Dr. Sambo. That we need to follow 4 thrusts, and the first one being push up to build all the capacity in the public health sector. And I think I saw it on your slides, Prof. That is the key. If we can do that, I'm quite sure that even before the 14 years that we're spoken about, things will start improving. And at the same time as we do that, because it's also in our National Planning Commission, we reduce the burden of diseases. As you're saying, it's one of the pillars, Eric, because last 2 weeks ago, we were in Addis Ababa. Ministers of health in Africa were having their biannual meeting. And the topic was non-communicable diseases. And I got very scared that some were proposing a curative system. And I said, and I'll keep on repeating it, as I said yesterday, the only thing that will take Africa out of this morass is a preventative healthcare system. Eradicate these diseases. Start making them go away. Don't try to treat them, because believe you me, Africa will never cope. We won't cope in treating cancer, for instance, with all the oncology equipment that is needed, the operation. We simply won't cope. We don't have resources to do so in Africa. We already have the biggest burden of HIV and AIDS, which is taking resources away. We are having the biggest burden of TB, which is taking resources away. If you then add non-communicable diseases and you think all of them you must treat, it's simply not going to happen on this continent. So this continent can only do it by putting up certain diseases and say, this one, let's tick off, we are eradicating. Like we are eradicating, like we are discussing Africa, in Southern Africa, that by 2018, we can eradicate malaria. We are already 85% towards that. We can completely eradicate it. We can eradicate polio. We are just next to. We can eradicate measles, if we so wish. Now that we are we have started immunization for rotavirus and pneumococcus, we can strengthen it. Next year when you launch, we must keep on choosing this and pushing them forward. That's the only way I think Africa is going to survive. Because I got scared when one colleague, hey, should I mention this? Yeah, I need to be very careful. Yes, when we were in Addis Ababa, one colleague describing how the country, I'm not going to mention which one in this case, is suffering under these non-communicable diseases, asking donors and said, can we be given more morphine? There's no morphine in my country. I said, now this is scary. Yes, by dealing with cancer, by asking for morphine. Because that's what was happening. I had to respond because I was in the panel. I said, no, but morphine is at death already. Yes, you are saying you want to start dealing with your people when they are dying already. That's the only time we give them morphine. I said, I thought you will say we must teach strategies on how to stop cancer from happening. Yes, how to stop cancer from happening and not look for morphine. So I think in NHI, that's exactly where we are going to put the emphasis to push that resource. And I keep on influencing the Minister of Finance. When I influenced him about the announcement we made yesterday, I didn't tell him how many people will be treated and all that. I mean, how many people will benefit and all that. That's not how you deal with ministers of finance. I gave them figures of treatment of cancer, how much money, and the figures of immunization. And he said, oh, no, go on, go on. That's how you deal with the minister of finance. You said to treat, it causes this. And I'm happy, Prof, that Harvard also called them. The minister of finance, I think it's last month. Right. Yes, and my deputy minister attended. And I'm confessing here, he didn't give me that permission, but I'm confessing it. When I spoke to him last week, I realized that he's a changed person. Yes. Yes, he's now, because the fear here of ministers of finance, when you talk about NHI, is money. That where are the resources going to come to? You're going to increase taxes, etc. I don't know what you told them in Harvard, but now I realize he was saying, hey, I think now this NHI is a good idea. Then he said, no, in Harvard they asked us what is our core function. And we said it's economic, to grow the economy. And they said, how do we grow economy with sick, dying people? How do you do that? And they started seeing it immediately. What actually you mean? The people are dying and sick, but you want to grow economy. It's not going to happen. So they are starting to understand, and that's why I want you to keep it up at that level. Give this information, teach about the Bismarckian method, allow us in Africa to look at the thrust of Dr. Sambo and say, if we don't start there, we'll keep on giving free services that don't exist. And people will start hating NHI. Thank you.